When I'm looking in patients' ears in clinic, everyone feels like they need to apologize. Oh, I'm so sorry. My ears are probably so dirty. and I'm always like, no, like your ears are fine. And they have the amount of wax that they need to have most of the time. I mean, there are situations where I have patients who either make a lot of wax or they have a really small ear canal, so it tends to get blocked off. That's the minority though. Most patients, over 90% of patients, don't need to do anything with their ears. So don't clean your ears. Don't use Q-tips. Just leave it alone. Just let it be.
You are listening to the Pinnacle Podcast, where we empower women in medicine through education, community, and actionable strategies for both the practice and the business of medicine.
Medicine is a lifelong career, and continuing education is crucial for professional development. Pinnacle is the first and only multi-specialty organization dedicated to addressing the challenges that all women in healthcare face.
Welcome to Pinnacle, the elite professional community providing education for women in medicine. At Pinnacle, we challenge you to pave your own path by helping you develop the skills needed to not only stay in medicine, but to excel. Welcome, everyone, to the Pinnacle Prescription Podcast. I'm your host, Dr. Rupa Wong, and today I'm joined by Dr. Ashley Agan for Ear, Nose, and Throat Basics, understanding the top causes of all primary care visits. Dr. Agan is a board-certified otolaryngologist. She is the founder of a concierge ENT practice in Dallas, Texas, and specializes in ear, nose, and throat disorders. She's also a member of the American College of Lifestyle Medicine and is an advocate for the power of lifestyle medicine to improve patient outcomes. Thank you so much for joining us today, Dr. Agan.
Thank you, Rupa. Please call me Ashley. I'm so excited to be here. Thank you for having me. Thank you to you and your team for creating Pinnacle and the Pinnacle Conference. This year was my first year to attend. And I must say, I just, being in a room with women that are movers and shakers and doing some really amazing things just was so inspiring. And I left feeling really empowered. So kudos to what you guys are doing. And thanks for allowing me to be a part of it.
I love it. And I'm so glad that you got to experience the Pinnacle community in person firsthand. I know you've been a part of the larger community virtually for a while and just through the Facebook group. So I'm so happy that it met your expectations. Before we get started on the podcast, did you have any June projects that you embarked upon after the May Pinnacle meeting?
So yeah, you mentioned my practice. So I started in March. We opened our doors in March. So we're very new right out of the gates, and so I have lots of projects that I've been able to take and implement immediately. Mostly things like building my referral network and getting out there on social media. Mostly doing a lot of things that I feel really self-conscious about and don't want to do, but am making myself do it anyway, because once you do it and then you realize the return on making yourself do it, then you kind of develop that muscle memory of being less afraid of doing it, and you overcome that fear.
I love it. And those are two topics we discussed at the conference. So hopefully that made you feel a little less self-conscious, knowing everyone else is doing it too. And some of them don't feel really confident about starting as well. So I really love that you shared that. Thank you. So let's just dive in to the meat of the podcast. What drew you to specialize in otolaryngology, and what excites you most about this field?
Yeah, I love this question. I was in medical education when I was at UT Southwestern, when I worked at the medical school, and I love working with medical students, and medical students love asking, why did you become an ENT?
Yes.
And I always, transport back to when I was a bright-eyed medical student, and I did my ENT rotation, just trying everything out, and, I love surgery. I guess, first things first, I did my surgery rotation. I was like, oh, this is it. Like working with my hands, see the problem, fix the problem. Like, I love this. And then in ENT, I love the the patient population we get to take care of. So, kids, young adults, older adults, end of life, the full spectrum. I love that we take care of a lot of quality of life issues, that significantly make people feel better. So like something as simple as being able to breathe through your nose, like I've had patients who literally like are almost in tears telling me like they're so happy they can breathe through their nose. And it's just, it's really fun. And it was just kind of a nice match for my personality and my skill set.
I love it. Actually ENT was it was between ophthalmology or ENT, and we all know those used to be one specialty back in the day. I was sharing that with another one of the ENT surgeons that we interviewed for the podcast. So I think just knowing whether you are a surgical person, kind of narrowing it down, right? First there, and then the medical. If you're more diagnostic, you like being a detective in that different kind of way clinically. I think that's such an important thing. And you mentioned you take care of the whole gamut. So you're a comprehensive ENT specialist. So you are doing babies also all the way to adulthood, or kind of the mix. Yeah.
Yeah, exactly. So in little kids, we might take care of tongue tie, in a baby that's, a week old. Recurrent ear infections is extremely common. Ear tubes is one of the most common surgeries, if not the most common surgery done in the country. As we move into adults, it's more, allergies, eustachian tube dysfunction. I have, my practice is kind of general all things, but I do have a niche in eustachian tube disorders. And so, for example, these are your patients who have the clogged, stuffy ears. Maybe they can't equalize the pressure when they fly or dive. So the eustachian tube is kind of blocked and not working. And I also take care of patients who have patchless eustachian tube, who have a eustachian tube that stays open too much and doesn't close when it's supposed to, which is also problematic. So,
I didn't even realize it was. So is it a valve? Forgive me if I sound really. Is it a valve system? What exactly is going on there?
It's a great question. It's kind of, the eustachian tube is tucked in the back of the nose and throat.
Right.
And so it's a part of the anatomy that most people don't think about. I think about it every day because it's something I see patients for. But yeah, it's a valve. The eustachian tube opens when we yawn, when we swallow throughout the day, and then it closes back together. And so it's necessary for it to be able to open and to also close. And so patients who have a eustachian tube that's not closing, which is called patchless, also have problems.
Okay, so you mentioned the tongue issue for babies, the recurrent ear infections, the eustachian tubes. What are other common things that you see, and then what are the approaches to fix them?
Sure. Other things that are extremely common, hearing loss, recurrent tonsillitis, recurrent sinusitis, generally any sort of recurrent infection that happens in this area, in the nose, in the throat, laryngopharyngeal reflux. So lots of people are familiar with GERD or heartburn type of gastroesophageal reflux. Laryngopharyngeal reflux is when you have reflux that's coming all the way up and beyond the upper esophageal sphincter. And so it can be liquid, it can be gas, and that's irritating the tissues of the larynx, pharynx, even up into the sinuses. You can have patients who have really recalcitrant sinusitis that's because of reflux. So that's a really common one. What else? Dizziness, vertigo, patients with recurrent vertigo, hoarseness.
Oh, what about, I've been seeing a lot of things too about throat clearing and seeing that come to more of the forefront, and that it's actually, there's reasons for it, not just a tick.
Yeah. So throat clearing and something called globus pharyngeus or globus sensation, when you kind of have this persistent feeling like there's something in your throat. And so that may be the trigger for kind of this constant throat clearing. And we, essentially when I'm seeing patients, my my exam, I have scopes in my toolkit that allow me to see into these places. So see into the nose and sinuses in the back of the nose, down into the throat, and we can kind of actually visualize in the office what your larynx, which your voice box is looking like. Is there mucus on the vocal cords or vocal folds that's causing that throat clearing or that sensation to want to throat clear? Is there, obviously the main thing we want to do is rule out that there's any sort of lesion. Is there a cancer or something suspicious on the vocal folds that may need to be biopsied? And so one of the things I love about ENT is that I can get a lot of information when the patients are right there in front of me in the office. I mean, some of them will look at, when I pull out my flexible scope, I tell them, I'm like, it's kind of like a piece of spaghetti. And then they look at me like, you're going to put that where? Like, what are you doing with that? but I love that we can get a lot of information without going to the operating room, which, is, I appreciate that I can look at the scope exam with the patient together, and they're like, what's this, what's that, and it's kind of like teaching them their anatomy.
I love it. Okay, so you explained basically some of the most common things that you see. Are these things that when they go and present first to their primary care physician, what should the primary care physician be able to handle? Can you give some tips for the internist or the pediatrician or the family practice doctor for these really common ENT diagnoses, for what they should be doing with them, or if they should just be referring, and then how you handle them, whether surgically or antibiotics or something else?
Yes, it's a really good question. And I'll start out with sudden hearing loss, because this is something that comes up frequently that may not be may not be known about kind of in the broader community outside of ENT. So sudden hearing loss, more specifically sudden sensory neural hearing loss, is one of the very few ENT emergencies. Mm-hmm. And so what will happen is, a patient might wake up one morning and suddenly be like, oh, I think I've got, water in my ear, or like maybe I got wax. I can't hear out of this ear. They might go to urgent care or their primary care doctor, and they look in there and they don't see anything. So if that happens, you need to send them to an ENT. But what happens sometimes is that, they might be looking in the eardrum and they might convince themselves, well, maybe it looks a little red, so let's start you on some antibiotics. And the issue with that is that in a situation of sudden sensory neural hearing loss, the time to act is immediately. We want to get patients on steroids, high-dose steroids, within the first 72 hours. Sometimes we do steroid injections as well in combination with oral steroids. Or if you have a patient with diabetes who can't tolerate the oral steroids, we'll do injections specifically for that. But what we don't want to happen is the patient takes the antibiotics, a couple weeks go by, it's still not better. They go back, doctor checks again, maybe they start on something else, maybe they refer, and then it takes a couple months to get into an ENT. And then they present and they're sitting in front of me saying, oh yeah, I had a sudden hearing loss 3 months ago. And then, it's like, the time to act is as soon as possible. So for me, if you're in my referral area and you send me a patient and you think like, oh, they had a sudden hearing loss, I don't think I see fluid, but I will never be mad at a false alarm, because the risk of missing the sudden sensory neural hearing loss is so high that I would rather see someone and it turn out, oh yeah, actually they do have some fluid there, or, oh, maybe it's something else, as opposed to missing that.
Oh, that is such a good pearl, because I didn't know that. There's an equivalent, of course, in optho, but
right.
I would never have suspected that unilateral sudden hearing loss is such a clinical emergency. I didn't realize there was a time frame on that. And it's great to know that hopefully other ENT surgeons within everyone else's geographic location feel similarly, that they would rather know about this. If you can call up your local ENT and tell them, hey, I've got a patient with sudden hearing loss, will you take them? They hopefully will feel the same way, that it doesn't take too long, even if it's not anything that requires urgent treatment other than antibiotics or something. So that's really helpful. Are there other clinical scenarios that are similar to that, or other just really common things?
Yeah, I think things that are really common, recurrent infections, for example, recurrent ear infections, recurrent sinus infections, recurrent tonsillitis. All of those are extremely common referrals, and there's a lot of published guidelines. So I think most of our primary care colleagues know when to refer those, because a lot of the times it's related to number of infections, or if there's intolerance to taking antibiotics, or things like this. And so surgery is extremely effective for all of those things. If you don't have tonsils anymore, you can't have tonsillitis. And so surgery works very well for things that are red flag things. So something like hoarseness. I would have a very low threshold to refer hoarseness. Acute laryngitis is very common. If it's in the setting of a recent upper respiratory infection where someone was coughing a lot, it's probably something benign, and you can treat, with steroids or antibiotics if you think there's still infection happening. But if it's been a couple of weeks, I would say send them to an ENT. That way we can at least look. Again, the concern is that we might be missing a malignancy, and we don't want months and months to go by and for you to take something that would have been a small resectable T1 cancer, and now it's kind of moved and grown and may, be a bigger operation. And so I would have a very low threshold to refer hoarseness that's persisting beyond, maybe 2 or 3 weeks.
Okay. Those are good to know. What about the converse? Are there particular areas that are particular diagnoses that you say are fine to go to your primary care physician, or primary care physicians should feel comfortable handling without a referral?
I think that a lot of the acute infections that come up make sense to go to, your primary care doctor. An ear infection, that's this summer months, swimmer's ear is very common. If you spend the weekend at the lake and then you start having a little bit of an ear infection, going in to see your primary care doctor or urgent care, usually they're going to start you on some antibiotics, and usually that's going to clear up. And if it doesn't, then see an ENT. I think, so with something like that, I would say if the ear canal swells so much that if you're using drops, if the drops can't get in there, then sometimes we may need to debride or suction out, the debris that's in there preventing the antibiotics from getting down, or we may need to place a wick that will help the antibiotics get all the way down into the ear canal. But as a first step, I think most patients with something like an acute infection are going to be treated just fine by seeing their primary care.
Oh, that's good to know. And just helpful for those of us where it's been a long time since medical school, so we don't remember those guidelines or the anatomy. And there's new treatments now also for a lot of the things that you were mentioning, which is great. You're also a really passionate advocate for lifestyle medicine. So how do you incorporate lifestyle changes into the treatment plans for your ENT patients?
Yes. So I must confess before we get into it, kind of how I found my way here.
Yes.
Because I was, in my 20s, I think I was probably in medical school, and I, wanted to trim up. I wanted to lose a little bit of weight. And I found a diet book called The Engine 2 Diet. I picked it up at a Whole Foods in Austin, and thinking that, I'm just going to like lose 10 pounds or whatever. But it's written by Rip Esselstyn, who is the son of Caldwell Esselstyn, who is a cardiologist and had been using a whole food plant-based diet to treat his cardiac patients for years. And so I was on this kind of whole food plant-based diet. And yeah, I lost some weight, but the other transformation around it was more powerful. So things like, I'm an ENT patient. I have allergies. I'm sneezy. I joke that I'm the sneezing ENT.
Me too.
And in medical school, it was horrible. So, I grew up in the Dallas-Fort Worth area, went to medical school down in Galveston, and the humidity and allergies down there there was a point where I didn't have skin left on my nose because I was just blowing my nose so much.
It's like scabbed over. I know
horrible.
exactly where you're coming from.
But so I made these diet changes where I was, actually eating, vegetables and getting a lot of fiber and, beans and whole grains. And after a few months, I was like, I haven't really had to use my nose spray as much. And then, it just kind of had like an aha moment about like, oh my gosh, like my allergies are way better. I think it's because of this diet. I noticed that my skin looked better. I had less acne. I just, from an overall health standpoint, I was like, wow, this is really amazing. So, flash forward many years, I would say I was on a pretty I would say strict, I was following that whole food plant-based diet, through residency. I was kind of on a saltine diet sometimes because you're just eating when you can eat really. And then you got to go back and scrub it, so probably was a little all over the place in residency, but still kind of, I had the evidence to show myself that there was, when I would feel my body kind of slipping, I'd be like, you know what, if I get back on that, I feel good. And so I've kind of had that personal evidence to show myself that I feel good when I eat well, which makes sense. I mean, that's not like a magical or mysterious thing, but implementation is the hard part, right? And then now, so in the last, 10 years or so, I've been a lot more excited about just having the time to be able to talk to patients about the power of lifestyle medicine. And for people who are not familiar with the American College of Lifestyle Medicine, lifestyle medicine basically has 6 pillars. And so one of them is diet and nutrition, but the others are, physical activity and exercise, stress management, sleep, avoidance of risky substances, so like smoking and alcohol, and social connection. And so with all the different things that I see, there is typically a link to one of those in there somewhere. So for example, let's say I'm talking to a patient. During my intake, I always try to touch on all of those and get a sense of where they're at with those things. So for the allergy patient, for example, I might ask about, diet, processed foods. Are you getting enough fiber? What's your gut health like? And kind of suss out whether or not they want to go there, right? If that's something that they're even interested in changing. But for people who are, it's exciting to kind of geek out about like, how you can, pull these different levers and change your diet to make you feel better and make your allergies better. It also, I think on the diet realm, reflux, so patients with laryngopharyngeal reflux, lifestyle modifications, looking at the diet, getting rid of the processed foods, drinking more water, like just straight up water, not bubbly water, right? Like everybody's got their, LaCroix these days and Topo Chico, but me too. I'm guilty. But if you're really trying to feel better, just like, doing a little test. Let's do a little test for the next month and see if we cut this out. Let's see how you feel. I think that's a little easier of a leap than saying like, you can never drink coffee again, or you can never, like we try to just like, let's just do some little tests, little self trial, see how it goes. I think it's fun. And there's so many, when you look at lifestyle medicine and these different pillars, people are receptive to different things. And, so I think it can kind of be this kind of self-guided tour through, getting the foundation better. Because I think that makes sense to me. And I think that makes sense to a lot of patients. Like if we can just from a foundation, get these 6 pillars sort of in order, then we can build on that. But if things are out of whack, if you're sleeping 3 hours a night and you're eating a bunch of junk food and you're totally stressed out and you're smoking and, it's really hard for me to make you better because these things are all out of whack. And I think that resonates for people.
I mean, that's probably true. I mean, that's true for everything, right? For every specialty, every probably diagnosis could benefit from just looking at things holistically. So, there's so much misinformation we know as we educate via podcasts, social media. There's a lot of misinformation about the types of home remedies that are helpful or even preventative tips that are helpful. So tell us, are there any that are truly beneficial for your patients?
Let me think of an example. So, I'll have patients who like to put different oil in their ear, maybe, to help with earache or, infection or other things, which, there's not a lot of evidence for using, olive oil, for example, in your ear. And depending on what's going on, sometimes I'm okay with it. And sometimes I, might say, let's pivot. So for example, if you have the patient who, has maybe some ear pain, but has had a negative workup for everything else, and it's soothing to put some olive oil in the ear, it's probably, that's pretty benign as long as they don't have a hole in their eardrum, right? So that's gonna maybe kind of moisturize the ear canal or help loosen up some wax. That's fine. If you have a youngster who's having recurrent ear infections, that oil is not really helping and could be hurting and delaying getting the right treatment. And so with little kids having recurrent ear infections, every time they have an infection, there's a lot of inflammation there. There's they have to be on antibiotics. If they're not on antibiotics, there's a risk for that infection spreading. The ear is right underneath the brain. We see kids in the hospital that have had a periosteal abscess where the infection travels to the mastoid or travels up. You can get these kids with meningitis. So it can get really scary. And I know that, parents are worried about all the antibiotics in such a young kid, so if you got a 1-year-old that's been on antibiotics a bunch, you're worried about what's it doing to their gut microbiome. And, now they're having diarrhea all the time. Now they have a rash, I get it. And then there's just the fear of okay, well, if we do ear tubes, now that means there's general anesthesia and it's a surgery, and that's also scary. But, I think overall the kind of looking at risks and benefits, ear tubes are generally very safe and so effective. Most families after ear tubes say, oh my gosh, I wish I'd have done this sooner, because they work so well for preventing infection, and they work so well for these kids who are walking around with a bunch of fluid in their ears. Right. Think about it, when you're underwater, you can't hear. And so a lot of these kids with recurrent infections, they have fluid. It's, it's sterile, but it's still just mucus and fluid and gunk sitting behind their eardrum, preventing their ability to hear well. And they're in a peak time for language development. And that's, it's really important for them to be able to hear as best as they can, and tubes work really, really well. And so I think, I recognize the aversion to antibiotics and surgeries, but putting, the eardrum is separating the ear canal from where the infection is for these kids who have ear infections. So anything that you're putting in the ear is not going to reach that infection because it's behind the eardrum. And then I'll just say, I know I've been talking for a lot.
No, that's great.
I'll just say there are devices now that allow us to place ear tubes in kids in the office. And
Wow.
so for the families who are worried about general anesthesia, there are devices where we can, it basically brings the myringotomy and the tube placement into one move. And so in about 5 seconds, we can get that tube in.
Amazing.
So, I think, I think ear tubes are in general make such a positive impact that I feel like the benefits outweigh the risk.
Absolutely. I have no idea about that technique for placing ear tubes without general anesthesia. I mean, that is the primary concern. I do tubes for the nasolacrimal system in babies, and it's, general anesthesia is a very real concern, but when the benefits outweigh the risks, especially with language development, as you were mentioning, it seems to be a no-brainer. Are there any other kind of home remedies that you've seen that are harmful that you wish to educate others in medicine so that they can know to watch out for, that it's not benign? You mentioned olive oil, pretty much benign for an adult, but are there things that are not so well tolerated?
So Q-tips, it is so common that when I'm looking in patients' ears in clinic, everyone feels like they need to apologize. Oh, I'm so sorry. My ears are probably so dirty. and I'm always like, no, like your ears are fine. And they have the amount of wax that they need to have most of the time. I mean, there are situations where I have patients who either make a lot of wax or they have a really small ear canal, so it tends to get blocked off. That's the minority, though. Most patients, over 90% of patients, don't need to do anything with their ears. So don't clean your ears. Don't use Q-tips. Just leave it alone. Just let it be, because you're just gonna, people are like, oh, but it feels so good. Like I just really need that Q-tip. You just don't do it.
Don't do it.
You're just going to push wax down in there against the eardrum or cause an abrasion or scratch the eardrum and cause infection. It's just, I've had patients who have accidentally perforated their eardrum with a Q-tip, which is horrible. But I can tell, if I look in your ear and there's this perfect little indentation of the head of a Q-tip, I will know that you've been Q-tipping, and I will tell you, don't do it. Resist.
Stop. I love that. That's very useful. I am sure there are a lot of closeted Q-tip users out there listening. All right. What is one last pinnacle pearl you wish to share with other women in medicine?
I love this question. I think just reflecting on, my own experience, I would say more recently, things that have been helpful for me is, really knowing your values. So doing that check-in of what are my values? What do I stand for? And does that align with how I'm spending my time? Because it's really easy to get busy with things that don't matter or that don't line up with your values, and it can make you really bitter. And I think, I definitely am guilty of, being a martyr and, sacrificing myself for my job. I would say that can't last. Like you're not going to be able to sustain that. I'm not saying don't work hard, because it's good to work hard. There's a lot of growth in doing hard things, and I like doing hard things. But I think if you can make sure that what you're doing is in line with your values, then I think even when you're doing something really hard and coming up against challenges, you can still have peace and equanimity with that, because you know what you stand for.
So well said. I love that. Just useful helpful advice for everyone to just, even if you know it, just to hear it again and to try to, because it's a work in progress, right? We're always striving. We have to reset sometimes that course. All right, Ashley, it's been so great talking with you today. Where can everyone find you?
Yes, let's see here. So my practice in Dallas is called Scotty. It's named after my grandmother. Her name was Shirley Ann Scott. She went by Scotty when she was a kid. So Scotty, my website is scottyent.com. So SCOTTIEENT.com. On Instagram, I'm Ashley Agan, MD. On Facebook and LinkedIn, I'm Ashley Agan. And then, can I plug Backtable?
Sure.
My podcast?
Yes, absolutely.
I host a podcast with my dear friend Gopi Shah. It's called Backtable ENT. It is a podcast about all things ENT. So if you just want to hear a couple, doctors talking shop about, some sort of ENT topic, check us out. The Backtable family has podcasts for interventional radiology, urology, OB-GYN, MSK, innovations. Hopefully I'm not forgetting one. But it's a great way to just kind of learn from each other. It's peer-to-peer. How do you do this one case? What catheter do you like to use for this? What do you do when the patients don't read the textbook and don't present like you think they're going to? And what do you do when you have this complication? It's that sort of thing. So backtable.com, check out the Backtable family of podcasts.
Love it. Sounds like such a great resource. And thank you so much for joining me today. It has been very eye-opening, and it's just been a pleasure. Thank you.
Thank you so much. I really appreciate the opportunity.
Thank you for listening to the Pinnacle Podcast, where we strive to elevate the voices of women in medicine and inspire excellence across the healthcare landscape. Until next time, keep reaching for your pinnacle.